Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Combination targeted therapy in relapsed diffuse large B-cell lymphoma. Background. The identification of oncogenic mutations in diffuse large B-cell lymphoma, DLBCL, has led to the development of drugs that target essential survival pathways. But whether targeting multiple survival pathways may be curative in DLBCL is unknown. Methods. We performed a single-center, Phase 1b/2 study of a regimen of venetoclax, ibrutinib, prednisone, obinutuzumab, and lenalidomide, Vipoor, in relapsed or refractory DLBCL. In Phase 1b, which included patients with DLBCL and indolent lymphomas, 4 dose levels of venetoclax were evaluated to identify the recommended Phase 2 dose, with fixed doses of the other 4 drugs. A Phase 2 expansion in patients with germinal center B-cell, GCB, and non-GCB, DLBCL, was performed. Vipoor was administered every 21 days for 6 cycles. Results. In Phase 1b of the study, involving 20 patients, 10 with DLBCL, a single dose-limiting toxic effect of grade 3 intracranial hemorrhage occurred, a result that established venetoclax at a dose of 800 mg as the recommended Phase 2 dose. Phase 2 included 40 patients with DLBCL. Toxic effects that were observed among all the patients included grade 3 or 4 neutropenia in 24% of the cycles, thrombocytopenia in 23%, anemia in 7%, and febrile neutropenia in 1%. Objective responses occurred in 54% of 48 evaluable patients with DLBCL, and complete responses occurred in 38%. Complete responses were exclusively in patients with non-GCB, DLBCL, and high-grade B-cell lymphoma, with rearrangements of MYC and BCL2, or BCL6, or both. Circulating tumor DNA was undetectable in 33% of the patients at the end of Vipoor therapy, with a median follow-up of 40 months. 2-year progression-free survival and overall survival were 34%, 95% confidence interval, CI, 21 to 47, and 36%, 95% CI, 23 to 49, respectively. Conclusions. Treatment with Vipoor was associated with durable remissions in patients with specific molecular DLBCL subtypes and was associated with mainly reversible adverse events. AP3 Christchurch Heterozygosity and Autosomal Dominant Alzheimer's Disease. Background. Variants in AP and PESIN1, encoding apolipoprotein E and presenilin 1, respectively, alter the risk of Alzheimer's disease. We previously reported a delay of cognitive impairment in a person with autosomal dominant Alzheimer's disease, caused by the PCN1E280A variant, who also had 2 copies of the apolipoprotein E3 Christchurch variant, A-Peach. Heterozygosity for the A-Peach variant may influence the age at which the onset of cognitive impairment occurs. We assessed this hypothesis in a population in which the PCN1E280A variant is prevalent. Conclusions. Clinical data supported a delayed onset of cognitive impairment in persons who were heterozygous for the A-Peach variant in a kindred with a high prevalence of autosomal dominant Alzheimer's disease. Non-invasive ventilation for preoxygenation during emergency intubation. Background. Among critically ill adults undergoing tracheal intubation, hypoxemia increases the risk of cardiac arrest and death. The effect of preoxygenation with non-invasive ventilation, as compared with preoxygenation with an oxygen mask, on the incidence of hypoxemia during tracheal intubation is uncertain. Results. Among the 1,301 patients enrolled, hypoxemia occurred in 57 of 624 patients, 9.1% in the non-invasive ventilation group, and in 118 of 637 patients, 18.5% in the oxygen mask group. Difference, minus 9.4 percentage points, 95% confidence interval, CI, minus 13.2 to minus 5.6, p less than 0.001. Cardiac arrest occurred in one patient, 0.2%, in the non-invasive ventilation group, and in 7 patients, 1.1% in the oxygen mask group. Difference, minus 0.9 percentage points, 95% CI, minus 1.8 to minus 0.1. Aspiration occurred in 6 patients, 0.9%, in the non-invasive ventilation group, and in 9 patients, 1.4%, in the oxygen mask group. Difference, minus 0.4 percentage points, 95% CI, minus 1.6 to 0.7. Conclusions. Among critically ill adults undergoing tracheal intubation, preoxygenation was. Non-invasive ventilation resulted in a lower incidence of hypoxemia during intubation than preoxygenation with an oxygen mask. A novel anti-CD38 monoclonal antibody for treating immune thrombocytopenia. Background. Immune thrombocytopenia, ITP, is an autoimmune disease characterized by autoantibody-mediated platelet destruction. Treatment with CM313, a novel anti-CD38 monoclonal antibody, can result in targeted clearance of CD38-positive cells, including plasma cells. Methods. We conducted a phase 1-2 open-label study to evaluate the safety and efficacy of CM313 in adult patients with ITP. CM313 was administered intravenously at a dose of 16 mg per kilogram of body weight every week for 8 weeks, followed by a 16-week follow-up period. The primary outcomes were adverse events and documentation of 2 or more consecutive platelet counts of at least 50 times 109 per liter within 8 weeks after the first dose of CM313. The status of peripheral blood, immune cells in patients, and changes in the mononuclear phagocytic system in passive mouse models of ITP receiving anti-CD38 therapy were monitored. Results. Of the 22 patients included in the study, 21, 95%, had 2 consecutive platelet counts of at least 50 times 109 per liter during the treatment period, with a median cumulative response duration of 23 weeks, interquartile range 17 to 24. The median time to the first platelet count of at least 50 times 109 per liter was 1 week, range 1 to 3. The most common adverse events that occurred during the study were infusion-related reaction in 32% of the patients and upper respiratory tract infection in 32%. After CD38 targeted therapy, the percentage of CD56 DIMPDIG16 plus natural killer cells, the expression of CD32B on monocytes in peripheral blood, and the number of macrophages in the spleen of the passive mouse models of ITP all decreased. Conclusions. In this study, anti-CD38 targeted therapy rapidly boosted platelet levels by inhibiting antibody-dependent cell-mediated cytotoxicity on platelets, maintained long-term efficacy by clearing plasma cells, and was associated with mainly low-grade toxic effects. Next, we will be discussing articles from Journal of American Medical Association. Povidone iodine versus chlorhexidine gluconate in alcohol for preoperative skin antisepsis. A randomized clinical trial. Importance: preoperative skin antisepsis is an established procedure to prevent surgical site infections, SSIs. The choice of antiseptic agent, povidone iodine or chlorhexidine gluconate, remains debated. Objective: to determine whether povidone iodine in alcohol is non-inferior to chlorhexidine gluconate in alcohol to prevent SSIs after cardiac or abdominal surgery. Design, setting, and participants: multicenter, cluster randomized, investigator masked, crossover, non-inferiority trial, 4,403 patients. undergoing cardiac or abdominal surgery in 3 tertiary care hospitals in Switzerland between September 2018 and March 2020 were assessed, and 3,360 patients were enrolled. Cardiac, N equals 2,187, 65%. Abdominal, N equals 1,173, 35%. The last follow-up was on July 1, 2020. Interventions over 18 consecutive months. Study sites were randomly assigned each month to either use Povidone iodine or Chlorhexidine gluconate, each formulated in alcohol. Disinfectants and skin application processes were standardized and followed published protocols. Results: a total of 1,598 patients, 26 cluster periods, were randomly assigned to receive Povidone iodine versus 1,762 patients, 26 cluster periods, to Chlorhexidine gluconate. Mean SD, age of patients, was 65.0 years, 39.0 to 79.0. In the Povidone iodine group, and 65.0 years, 41.0 to 78.0, in the Chlorhexidine gluconate group. Patients were 32.7% and 33.9% female, in the Povidone iodine and Chlorhexidine gluconate groups, respectively. SSIs were identified in 80 patients, 5.1%, in the Povidone iodine group versus 97, 5.5%. In the Chlorhexidine gluconate group, a difference of 0.4%, 95% CI, minus 1.1% to 2.0%. With the lower limit of the CI not exceeding the predefined non-inferiority margin of minus 2.5%, results were similar when corrected for clustering. The unadjusted relative risk for Povidone iodine versus Chlorhexidine gluconate was 0.92. 95% CI, 0.69 to 1.23. Non-significant differences were observed following stratification by type of surgical procedure. In cardiac surgery, SSIs were present in 4.2% of patients with Povidone iodine versus 3.3% with Chlorhexidine gluconate. Relative risk, 1.26, 95% CI, 0.82 to 1.94. In abdominal surgery, SSIs were present in 6.8% with Povidone iodine versus 9.9% with Chlorhexidine gluconate. Relative risk, 0.69, 95% CI, 0.46 to 1.02. Conclusions and relevance: Povidone iodine in alcohol, as preoperative skin antisepsis, was non-inferior to Chlorhexidine gluconate in alcohol in preventing SSIs after cardiac or abdominal surgery. Dapagliflozin for critically ill patients with acute organ dysfunction. The Defender randomized clinical trial. Importance: sodium glucose cotransporter 2, SGLT, inhibitors improve outcomes in patients with type 2 diabetes, heart failure, and chronic kidney disease, but their effect on outcomes of critically ill patients with organ failure is unknown. Objective: to determine whether the addition of dapagliflozin, an SGLT2 inhibitor, to standard intensive care unit, ICU, care improves outcomes in a critically ill population with acute organ dysfunction. Design, setting, and participants: multi-center, randomized, open-label, clinical trial conducted at 22 ICUs in Brazil. Participants with unplanned ICU admission and presenting with at least one organ dysfunction, respiratory, cardiovascular, or kidney, were enrolled between November 22, 2022, and August 30, 2023, with follow-up through September 27, 2023. Intervention participants were randomized to 10 mg of dapagliflozin, intervention, N equals 248, plus standard care, or to standard care alone, control, N equals 259, for up to 14 days, or until ICU discharge, whichever occurred first. Main outcomes and measures. The primary outcome was a hierarchical composite of hospital mortality, initiation of kidney replacement therapy, and ICU length of stay through 28 days, analyzed using the win ratio method. Secondary outcomes included the individual components of the hierarchical outcome, duration of organ support-free days, ICU, and hospital stay, assessed using Bayesian regression models. Results among 507 randomized participants. Mean age, 63.9. SD, 15 years. 46.9%. Women, 39.6% had an ICU admission due to suspected infection. The median time from ICU admission to randomization was 1 day, IQR, 0 to 1. The win ratio for Dapagliflozin for the primary outcome was 1.01, 95% CI, 0.90 to 1.13, p equals 0.89. Among all secondary outcomes, the highest probability of benefit found was 0.90 for Dapagliflozin regarding use of kidney replacement therapy among 27 patients. 10.9% in the Dapagliflozin group versus 15.1% in the control group. Conclusion and relevance. The addition of Dapagliflozin to standard care for critically ill patients and acute organ dysfunction did not improve clinical outcomes. However, confidence intervals were wide and could not exclude relevant benefits or harms for Dapagliflozin. Next, we will be discussing articles from Annals of Internal Medicine. Sodium glucose cotransporter 2 inhibitors, and the risk for dialysis and cardiovascular disease in patients with stage 5 chronic kidney disease. Background. No studies have reported the long-term outcomes of initiating sodium glucose cotransporter 2 inhibitors, SGLT2, in patients with estimated glomerular filtration rates less than 20 milliliters per minute, /1.73 square meters to predialysis. Objective: to compare the risk for dialysis, cardiovascular events, and death between SGLT2I users and non-users in patients with type 2 diabetes, T2D, and stage 5 chronic kidney disease, CKD. Results. In the intention to treat model, compared with no SGLT2I use, SGLT2I use was associated with lower risks for dialysis, hazard ratio, HR, 0.34, 95% CI, 0.27 to 0.43, hospitalization for heart failure, HR, 0.80, CI, 0.73 to 0.86, AMI, HR, 0.61, CI, 0.52 to 0.73, DKA, HR, 0.78, CI, 0.71 to 0.85, and AKI, HR, 0.80, CI, 0.70 to 0.90, but there was no difference in the risk for all-cause mortality, HR, 1.11, CI, 0.99 to 1.24. The Kaplan-Meier curves and subgroup analyses also showed that initiation of an SGLT2I in stage 5 CKD was associated with a lower risk for long-term dialysis than no SGLT2I use. Limitation. This result may not apply to patients without T2D. Conclusion. This emulated target trial showed that SGLT2I use was associated with a lower risk for dialysis, cardiovascular events, DKA, and AKI than no SGLT2I use in patients with T2D and stage 5 CKD. Next, we will be discussing articles from British Medical Journal. Lateral episiotomy or no episiotomy in vacuum, assisted delivery in nulliparous women, EVA multicenter, open-label, randomized controlled trial. Objective: to assess the effect of lateral episiotomy, compared with no episiotomy, on obstetric anal sphincter injury in nulliparous women requiring vacuum extraction. Design a multicenter, open-label, randomized controlled trial. Setting 8 hospitals in Sweden, 2017-23. Participants 717 nulliparous women with a single live fetus of 34 gestational weeks or more, requiring vacuum extraction were randomly assigned, 1-to-1, to lateral episiotomy or no episiotomy, using sealed opaque envelopes. Randomization was stratified by study site. Results from July 1, 2017 to February 15, 2023, 717 women were randomly assigned, 354, 49%, to lateral episiotomy and 363, 51%, to no episiotomy. Before vacuum extraction attempt, 1 woman withdrew consent, and 14 had a spontaneous birth, leaving 702 for the primary analysis. In the intervention group, 21.6% of 344 women sustained obstetric anal sphincter injury, compared with 47.13% of 358 women in the comparison group, p equals 0.002. The risk difference was minus 7.0%, 96% CI, minus 11.7% to minus 2.5%. The risk ratio adjusted for site was 0.47, 96% CI 0.23 to 0.97, and unadjusted risk ratio was 0.46, 0.28 to 0.78. No significant differences were noted between groups in postpartum pain, blood loss, neonatal outcomes, or total adverse events, but the intervention group had more wound infections and dehiscence. Conclusions: lateral episiotomy can be recommended for nulliparous women requiring vacuum extraction to significantly reduce the risk of obstetric anal sphincter injury. Next, we will be discussing articles from Journal of Clinical Oncology, Impact of Broadening, Trial Eligibility Criteria, on the inclusion of patients with brain metastases in cancer clinical trials, time series analyses, for 2012 to 2022. Purpose. In October 2017, an ASCO, Friends of Cancer Research, FOCR, and U.S. Food and Drug Administration, ASCO/FOCR/FDA, Task Force, recommended that common eligibility criteria be modified to make trials more inclusive. We examined whether patterns of exclusions regarding patients with brain metastases changed over time in relation to these recommendations. Methods. Trial eligibility criteria were abstracted from clinicaltrials.gov for Phase I/III U.S.-based interventional clinical trials for patients with advanced breast, colorectal, lung, or melanoma cancers from January 2012 to December 2022. Trials were examined to determine whether patients with brain metastases were not excluded, conditionally excluded, excluded in some circumstances, or wholly excluded. An interrupted time series analysis with multinomial logistic regression was used to determine whether the ASCO/FOCR/FDA recommendations were associated with changes in brain metastases criteria. Results. We evaluated N equals 3,077 trials. Patients with brain metastases were not excluded in 506 trials, 16.4%, conditionally excluded in 2,263 trials, 73.5%, and wholly excluded in 308 trials, 10.0%. In the post-recommendation period, we estimated a 68% increase in the odds of brain metastases not excluded compared with conditionally excluded. Odds ratio, 1.68, 95% CI, 1.06 to 2.66, p equals 0.03. The proportion of trials in which patients with brain metastases were not excluded increased from 11.5%, v 17.3%, and conditionally excluded decreased from 82.3% to 75.2%, p equals 0.03. We found no difference in the proportion of trials in which patients with brain metastases were wholly excluded, 7.5% v 6.2%, p equals 0.42. Conclusion. The ASCO/FOCR/FDA Task Force recommendations were associated with a shift in patterns of brain metastases exclusion criteria from conditionally excluded to not excluded. These findings demonstrate that the cancer clinical trial community has begun to change the way trials are written to be more inclusive. Next, we will be discussing articles from Clinical Gastroenterology. Glucagon-like peptide 1 receptor agonist, use in patients with liver cirrhosis and type 2 diabetes. Background and aims. Liver cirrhosis is often associated with type 2 diabetes, T2D, but research on treatment of T2D in cirrhotic patients is scarce. We investigated the long-term outcomes of glucagon-like peptide 1 receptor agonists, GLP-1RAs, in patients with T2D and cirrhosis. Methods. Using propensity score matching, we selected 467 matched pairs of GLP-RA users and non-users from the National Health Insurance Research Database of Taiwan from January 1, 2008 to December 31, 2019. Multivariable adjusted Cox proportional hazards models were used to compare the outcomes between GLP-1 RA users and non-users. Results. The mean follow-up time was 3.28 and 3.06 years for GLP-1 RA users and non-users, respectively. The rates of death were 27.46 and 55.90 per 1,000 person-years for GLP-1 RA users and non-users, respectively. The multivariable adjusted models showed that GLP-1 RA users had lower risks of mortality. Adjusted hazard ratio, AHR, 0.47, 95% confidence interval, CI, 0.32 to 0.69, cardiovascular events, AHR, 0.6, 95% CI, 0.41 to 0.87, decompensated cirrhosis, AHR, 0.7, 95% CI, 0.49 to 0.99, hepatic encephalopathy, AHR, 0.59, 95% CI, 0.36 to 0.97, and liver failure, AHR, 0.54, 95% CI, 0.34 to 0.85, than non-users. Conclusions. This population-based cohort study showed that GLP-1 RA users exhibited a significantly lower risk of death, cardiovascular events, decompensated cirrhosis, hepatic encephalopathy, and liver failure in patients with T2D and compensated liver cirrhosis. Additional studies are needed to confirm our results. Coconut water induces clinical remission in mild to moderate ulcerative colitis, double-blind placebo-controlled trial. Background and aims. Coconut water, CW, is anti-inflammatory, can manipulate the gut microbiome, and is a rich source of potassium. Gut microbiome modulation improves outcomes in ulcerative colitis, UC, and potassium possesses in vitro anti-inflammatory property. We evaluated the effect of CW as an adjunct therapy for patients with mild-moderate UC. Methods. This single-center, double-blind, placebo-controlled trial randomized patients with mild to moderate, simple clinical colitis activity index, SACAI, 3 to 9, endoscopically active UC, ulcerative colitis endoscopic index of severity, UCS, greater than 1, in 1-to-1 ratio to CW plus standard medical therapy, SMT, versus placebo plus SMT. 400 milliliter of CW was administered for 8 weeks. Primary outcome measure was clinical remission, SACAI less than or equal to 2, and secondary outcome measures were clinical response, SACAI decline greater than or equal to 3, and adverse events at 8 weeks. Microbiome was analyzed at baseline and 8 weeks. Results. Of 121 patients screened, 95 were included for modified intention to treat analysis. CW, N equals 49, placebo, N equals 46, mean age, 37.2 plus or minus 11.2 years, males, 54.1%, disease duration, 48 months, interquartile range, IQR, 24 to 90 months, pancolitis, 26.1%, SACAI 5, IQR, 4 to 6, euciaceous, 4, IQR, 3 to 5. Clinical response, 57.1% versus 28.3%, odds ratio, OR, 3.4, 95% confidence interval, CI, 1.4 to 7.9, P equals 0.01, remission, 53.1% versus 28.3%, or 2.9, 95% CI, 1.2 to 6.7, P equals 0.02, and proportion of patients with fecal calprotectin, FCP, less than 150 g/g, 30.6% versus 6.5%, or 6.3, 95% CI, 1.7 to 23.6, P equals 0.003, were significantly higher in CW. The relative abundance of bacterial taxa that had a significant or trend towards negative correlation with Sakai, UCS, or FCP, increased at 8 weeks in CW, and this effect was independent of disease activity and dietary fiber. Adverse events were comparable, and no patient developed hyperkalemia. Conclusions. CW was more effective than placebo for induction of clinical remission in patients with mild to moderate UC. Next, we will be discussing articles from Journal of Clinical Rheumatology. Factors associated with distress related to perceived dignity in patients with rheumatic diseases. Background. The loss of perceived dignity is an existential source of human suffering, described in patients with cancer and chronic diseases, and hospitalized patients, but rarely explored among patients with rheumatic diseases, RMDs. We recently observed that distress related to perceived dignity, DPD, was present in 26.9% of Mexican patients with different RMDs. The study aimed to investigate the factors associated with DPD. Methods. This cross-sectional study was performed between February and September 2022. Consecutive patients with RMDs completed patient-reported outcomes to assess mental health, disease activity/severity, disability, fatigue, quality of life, call, satisfaction with medical care, and family function, and had a rheumatic evaluation to assess disease activity status and comorbidity, socio-demographic variables and disease-related and treatment-related variables were retrieved with standardized formats. DPD was defined based on the Patient Dignity Inventory Score. Multivariate regression analysis was used. Results. 400 patients were included and were representative of outpatients with RMDs, while 7.5% each were inpatients and patients from the emergency care unit. There were 107 patients, 26.8%, with DPD. Past mental health-related comorbidity, odds ratio, or 4.680, 95% confidence interval, CI, 1.906 to 11.491. The number of immunosuppressive drugs/patient, OR, 1.683, 95% CI, 1.015 to 2.791. The Physical Health Dimension Score of the World Health Organization Quality of Life, Brief Questionnaire, HUCAL-BREF, 0.937, 95% CI, 0.907 to 0.967, and the Emotional Health Dimension Score of the HUCAL-BREF, 0.895, 95% CI, 0.863 to 0.928, were associated with DPD. Conclusions. DPD was present in a substantial proportion of patients with RMDs and was associated with mental health-related comorbidity, disease activity/severity related variables, and the patient call. Next, we will be discussing articles from Arthritis and Rheumatology. Fractures in patients with acute calcium pyrophosphate crystal arthritis versus matched comparators in a large cohort study. Objective. Calcium pyrophosphate deposition, CPPD, disease, was associated with osteopenia in 2 cross-sectional studies. We compared fracture risks in patients with acute calcium pyrophosphate, CPP, crystal arthritis versus matched comparators. Methods. We performed a longitudinal cohort study using electronic health record data from a single large academic health system, with data from 1991 to 2023. Patients with 1 or more episodes of acute CPP crystal arthritis were matched to comparators on the index date. First documentation of pseudogout or synovial fluid CPP crystals or matched encounter, and first encounter in the health system. The primary outcome was first fracture at the humerus, wrist, hip, or pelvis. We excluded patients with fracture before the index date. Covariates included demographics, body mass index, smoking, comorbidities, healthcare use, glucocorticoids, and osteoporosis treatments. We estimated incidence rates and adjusted hazard ratios for fracture. Sensitivity analyses excluded patients prescribed glucocorticoids, patients prescribed osteoporosis treatments, or patients with rheumatoid arthritis, and additionally adjusted for chronic kidney disease. Results. We identified 1,148 patients with acute CPP crystal arthritis, matched to 3,730 comparators, with a mean age of 73 years. Glucocorticoids and osteoporosis treatments were more frequent in the acute CPP crystal arthritis cohort. Fracture incidence rates were twice as high in the acute CPP crystal arthritis cohort, 11.7 per 1,000 person-years, versus comparators, 5.5 per 1,000 person-years. After multivariable adjustment, fracture relative risk was twice as high in the acute CPP crystal arthritis cohort. Hazard ratio 1.8, 95% confidence interval 1.3 to 2.3. Results were similar in sensitivity analyses. Conclusion. In this first published study of fractures and CPPD, fracture risk was nearly doubled in patients with acute CPP crystal arthritis. Next, we will be discussing articles from circulation. Effect of gamification, financial incentives, or both, to increase physical activity among patients at high risk of cardiovascular events. The Be Active randomized controlled trial. Background. Physical activity is associated with a lower risk of major adverse cardiovascular events, but few individuals achieve guideline-recommended levels of physical activity. Strategies informed by behavioral economics increase physical activity, but their longer-term effectiveness is uncertain. We sought to determine the effect of behaviorally designed gamification, loss-framed financial incentives, or their combination on physical activity compared with attention control over 12-month intervention and 6-month post-intervention follow-up periods. Results. A total of 1,062 patients, mean plus or minus age, 67 plus or minus 8, 61% female, 31% non-white, were enrolled. Compared with control subjects, participants had significantly greater increases in mean daily steps from baseline during the 12-month intervention in the gamification arm, adjusted difference, 538.0, 95% CI, 186.2 to 889.9. P equals 0.0027. Financial incentives arm, adjusted difference, 491.8, 95% CI, 139.6 to 844.1. P equals 0.0062, and gamification plus financial incentives arm, adjusted difference, 868.0, 95% CI, 516.3 to 1,219.7. P less than 0.0001. During the 6-month follow-up, physical activity remained significantly greater in the gamification plus financial incentives arm than in the control arm, adjusted difference, 576.2, 95% CI, 198.5 to 954. P equals 0.0028, but it was not significantly greater in the gamification, adjusted difference, 459.8, 95% CI, 82.0 to 837.6. P equals 0.0171, or financial incentives, adjusted difference, 327.9, 95% CI, minus 50.2 to 706. P equals 0.09, arms after adjustment for multiple comparisons. Conclusions. Behaviorally designed gamification, loss-framed financial incentives, and the combination of both increased physical activity, compared with control over a 12-month intervention period, with the largest effect in gamification plus financial incentives. These interventions could be a useful component of strategies to reduce cardiovascular risk in high-risk patients. Next, we will be discussing articles. American College of Cardiology. TAVR, or SAVR for failed bioprosthetic aortic valves. Study questions. How do mortality and morbidity compare after valve and valve, VIVE, transcatheter aortic valve replacement, TAVR, versus redo surgical aortic valve replacement, SAVR, for intervention for a failed bioprosthetic SAVR? Methods. In a retrospective, population-based cohort study, statewide mandatory administrative databases in California, California Department of Healthcare Access and Information, New York, New York Statewide Planning and Research Cooperative System, and New Jersey Discharge Data Collection System, were used to identify patients who underwent January 2015 through December 2022. VIAF-TAVR, or isolated redo saver, greater than 5 years after bioprosthetic saver, excluding out-of-state residents and patients with infective endocarditis. A total of 1,771 patients were identified. Propensity matching yielded 375 patient pairs. The primary outcome measure was all-cause mortality. Secondary outcomes were stroke, heart failure hospitalization, HFH, reoperation, major bleeding, acute kidney failure, new pacemaker insertion, and infective endocarditis. Results. Median, interquartile range, follow-up, was 2.3, 1.1 to 4.0 years. From 2015 through 2020, the proportion of patients undergoing VIAF-TAVR versus redo saver increased from 159,451, 35.3%, to 498,797, 62.5%. Of 1,771 patients, 653, 36.9%, were female, and mean age was 74.4, plus or minus 11.3 years. Peri-procedural mortality and stroke rates were similar between propensity-matched groups. The VIAF-TAVR group had lower peri-procedural rates of major bleeding, 2.4% versus 5.1%, p equals 0.05, acute kidney failure, 1.3% versus 7.2%, p less than 0.001, and new pacemaker implantation, 3.5% versus 10.9%, p less than 0.001. Conclusions. Compared with redo saver, VIAF-TAVR was associated with a lower incidence of peri-procedural complications and a similar incidence of all-cause mortality through 2-year follow-up. However, VIAF-TAVR was associated with higher rates of late mortality and HFH. The authors note that these findings may be influenced by residual confounding and require adjudication in a randomized clinical trial. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Parathyroidectomy improves bone density in women with primary hyperparathyroidism and preoperative osteopenia. Context. Osteoporosis and/or bone fractures are indications of parathyroidectomy in primary hyperparathyroidism, PHPT, especially in women. However, the benefit of surgery in patients with osteopenia remains unclear. Objective. To evaluate bone mineral density, BMD, and bone remodeling biomarkers, changes 1 year after parathyroidectomy in women with PHPT. Design. In the prospective, monocentric, observational prospective cohort, with primary hyperparathyroidism patients, co-HPT, cohort, women operated for sporadic PHPT since 2016, with greater than or equal to 1-year follow-up were included. BMD, dual X-ray absorptiometry, and bone remodeling biomarkers. Cross-linked C-telepeptide, CTX, procollagen type 1, N-terminal propeptide, P1NP, and bone-specific alkaline phosphatase were assessed before and 1 year after parathyroidectomy. Setting. Referral center. Patients. A total of 177 women with PHPT, 62.5, plus or minus 13.3 years, 83.1% menopausal, 43.9% osteopenic, and 45.1% osteoporotic were included. Intervention. Parathyroidectomy. Main outcome measure. BMD change between before and 1 year after parathyroidectomy. Results. Parathyroidectomy resulted in significant increase in BMD and decrease in serum bone remodeling biomarker concentrations. In the 72 patients with baseline osteopenia, mean BMD significantly increased at the lumbar spine, plus 0.05 g/cmep2, 95% confidence interval, CI, 0.03 to 0.07. The femoral neck, plus 0.02 g/cmep2, 95% CI 0.00 to 0.04. The total hip, plus 0.02 G/cmAb2, 95% CI 0.01 to 0.02, and the forearm, plus 0.01, 95% CI, 0.00 to 0.02, comparable to osteoporotic patients. Among osteopenic patients, those with individual BMD gain greater than 0.03 G/cmAb2 at greater than or equal to one site had higher preoperative serum CTX, P1NP, and urine calcium concentrations than those without improvement. Conclusion: parathyroidectomy significantly improved BMD and remodeling biomarkers in women with osteopenia, thereby supporting the benefit of parathyroidectomy in these patients. Preoperative serum CTX and P1NP concentrations could be useful to predict expected BMD gain. Next, we will be discussing articles from Neurology. Cardiopulmonary coupling spectrogram as an ambulatory method for assessing sleep disorders in patients with autoimmune encephalitis. Background and objectives. Sleep disorders are a common and important clinical feature in patients with autoimmune encephalitis, AE. However, they are poorly understood. We aimed to evaluate whether cardiopulmonary coupling, CPC, an electrocardiogram-based portable sleep monitoring technology, can be used to assess sleep disorders in patients with AE. Methods. Patients fulfilling the diagnostic criteria of AE were age and sex matched with recruited healthy control subjects. All patients and subjects received CPC testing between August 2020 and December 2022. Demographic data, clinical information, and Pittsburgh Sleep Quality Index, PSQI, scores were collected from the medical records. Data analysis was performed using R language programming software. Results. There were 60 patients with AE, age 26.0, 19.8 to 37.5 years, male 55%, and 66 healthy control subjects, age 30.0, 25.8 to 32.0 years, male 53%, included in this study. Compared with healthy subjects, patients with AE had higher PSQI scores, 7.00, 6.00 to 8.00, versus 3.00, 2.00 to 4.00, P less than 0.001, lower sleep efficiency, SE 80%, 71% to 87%, versus 92%, 84% to 95%, P less than 0.001, lower percentage of high-frequency coupling, 25%, 14% to 43%, versus 45%, 38% to 53%, P less than 0.001. Higher percentage of REM sleep, 19%, plus or minus 9%, versus 15% plus or minus 7%, P less than 0.001. Higher percentage of wakefulness, W percent 16%, 11% to 25%, versus 8%, 5% to 16%, P equals 0.074. Higher low frequency to high frequency ratio, LF/HF 1.29, 0.82 to 2.40, versus 0.91, 0.67 to 1.29, P equals 0.001, and a higher CPC-derived respiratory disturbance index, 9.78, 0.50 to 22.2, versus 2.95, 0.40 to 6.53, P less than 0.001. Discussion. Sleep disorders with autonomic dysfunction are common in patients with AE. Improvements in the PSQI score and SE precede the restoration of sleep microstructural disruption in the remission stage. CPC parameters may be useful in predicting sleep disorders in patients with AE. Next, we will be discussing articles from Chest Volume 165, Issue 5 P10 25 1272, E133, E162. Effect of atypical sleep EEG patterns on weaning, from prolonged mechanical ventilation. Background. Approximately one-third of acute ICU patients display atypical sleep patterns that cannot be interpreted by using standard EEG criteria for sleep. Atypical sleep patterns have been associated with poor weaning outcomes in acute ICUs. Research question: do patients being weaned from prolonged mechanical ventilation experience atypical sleep EEG patterns, and are these patterns linked with weaning outcomes? Study design and methods. EEG power spectral analysis during wakefulness and overnight polysomnogram were performed on alert, non-delirious patients at a long-term acute care facility. Results: 44 patients had been ventilated for a median duration of 38 days at the time of the polysomnogram study. 11 patients, 25%, exhibited atypical sleep EEG. During wakefulness, relative EEG power spectral analysis revealed higher relative delta power in patients with atypical sleep than in patients with usual sleep. 53% versus 41%, p less than 0.001, and a higher slow-to-fast power ratio during wakefulness, 4.39 versus 2.17, p less than 0.001. Patients with atypical sleep displayed more subsyndromal delirium, 36% versus 6%, p equals 0.027, and less rapid eye movement sleep, 4% versus 11% total sleep time, p less than 0.02. Weaning failure was more common in the atypical sleep group than in the usual sleep group, 91% versus 45%, p equals 0.013. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Evaluation and measurement properties of a patient-reported experience measure for home dialysis. Background: no previously validated patient-reported experience measures exist for use among patients undergoing home dialysis. We tested the Home Dialysis Care Experience Survey, a newly developed 26-item experience measure, among patients from 30 dialysis facilities in the United States. Methods: using mail and telephone survey modalities, we approached 1,372 patients treated with peritoneal dialysis or home hemodialysis for participation. Using the results from completed surveys, we evaluated item calibration by assessing item floor and ceiling effects. We tested 3 sets of composite scores and used factor analysis to assess model fit for each. We evaluated associations of composite scores with global ratings and separately with patient and dialysis facility characteristics. Finally, we measured test-retest reliability in patients who completed the survey at 2 separate time points. Results: overall, 495 eligible patients completed at least one survey, response rate 36%. Of these, 49 completed the survey in Spanish, and 61 completed a second survey within 30 days. We did not detect significant floor or ceiling effects, except for one item that demonstrated more than 90% responses at the top response option. Analyses supported one 12-item composite scale with high internal consistency reliability, quality of home dialysis care and operations, Cronbach alpha, equals 0.85. This scale strongly correlated with overall staff rating, R equals 0.73, and overall center rating, R equals 0.70. Patient demographic and dialysis facility characteristics were not consistently associated with composite scale scores or overall staff or center ratings. Intro-class correlation coefficients in the test-retest population were 0.74 for the quality scale, 0.88 for overall staff rating, and 0.90 for overall center rating. Conclusions: the Home Dialysis Care Experience Survey is a 26-item measure that includes one composite scale and 2 global rating scores and is an informative tool to evaluate patient experience of care for home dialysis. Next, we will be discussing articles is from Kidney International Reports. Lithium-associated kidney failure, predictors and outcomes. Introduction. Despite the widespread use of lithium for bipolar disorders and depression, little is known about the characteristics of patients with lithium-associated kidney failure receiving kidney replacement therapy, KRT, methods. We conducted a retrospective study using the Australian and New Zealand Dialysis and Transplant Registry, ANS data, to investigate the predictors and outcomes of patients with lithium-associated kidney failure receiving KRT, Results. A total of 437 patients with lithium-associated kidney failure were compared to 1,280 ANSTATA-allocated controls of patients with kidney failure not associated with lithium. Patients with lithium-associated kidney failure commenced KRT at significantly older age, 62 plus or minus 10 versus 58 plus or minus 15 years, p less than 0.001, and were more likely to be European, 93% versus 68%, p less than 0.001, to be female, 63% versus 40%, p less than 0.001, and to live in a postcode with a higher socioeconomic status, SES, p less than 0.001. In patients with lithium-associated kidney failure, there were lower rates of coronary artery disease, 17% versus 37%, p less than 0.001, peripheral vascular disease, 7% versus 25%, p less than 0.001, cerebrovascular disease, 8% versus 14%, p equals 0.004, and diabetes mellitus, 16% versus 47%, p less than 0.001. There were no differences between first KRT modality, although kidney transplantation and retransplantation rates were lower, 21% versus 27%, p equals 0.008, 0.2% versus 3%, p equals 0.001. With shorter wait times to first transplantation, 20 months versus 29 months, p equals 0.02, in the patients with lithium-associated kidney failure. Rates of at least one rejection episode was comparable, 21% versus 22%, p equals 0.85, between the two groups. In addition, there were no survival differences, regardless of KRT modality between the two groups. Conclusion. Lithium-associated kidney failure represents a unique cohort, which is predominantly older, female, European, with a higher SES, and less comorbidities. Despite this, there are no differences in survival. Given the lower rate of transplantation, barriers to transplantation need further exploration.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.